Rồi anh nói trực tiếp vô luôn phải không?
Cái này nó không có loa hay gì đó, nên mình
nói trực tiếp rồi người ta cũng sẽ nói trực tiếp qua cái này
nói
thôi.
chỉ sai cái này.
Không chưa mở ra rồi hả?
Thì đúng rồi, giờ đây lớp quản lý thằng này em mở được này có.
Ủa, kéo qua kéo lại nè.
Dạ, thì mình có thể tắt trực tiếp trên
thôi tắt gì em cứ để nó đi, có gì em tắt mở trực tiếp.
Dạ.
Ủa rồi cho người ta kết nối vô sao em?
Thì nó cũng như
đây nè, bây giờ làm sao anh cho người ta kết nối vô?
đây, admit on
rồi.
That you can go get in now. No, you can get in now. Can you get in?
Còn một người chưa admit rồi.
Yeah, okay. Please admit Dr. Abi.
Waiting room.
Hết rồi.
Bấm vô waiting room đó rồi, đó có thể admit. Yeah.
Are you in? Okay, you in. Yeah. Can you
được rồi.
Hello. Oh, it's on mute.
Nói là bên kia đang kêu.
How are you?
Good. You can share your slides.
It says that the host disabled sharing of the slide.
Oh, only host Anh Quang. Can you
Ủa làm sao cho bên đó share like
Anh Quang vô cái share đó, share screen đó. Click on that.
If you make me a co-host or you let others share the screen, then it would work, I think. I'm a co-host. Okay, share screen. Okay, hold on. Hold on. Diane, can you see my screen?
Hello, can you hear me, Dr. Ding?
Yes. Abi, I don't see your title, only see your name.
No,
and
that's right. I have to click it through.
Okay.
Oh, wait. Good?
Hello,
That's
Dr.
good.
Ding. Hello, Dr. Abi. I'm Dr.
Hi,
Quang,
how are you?
Head of Department of Nephrology and Endocrinology, Children's Hospital number 1. I'm very happy to see you here, and you share your busy time to join in this webinar and share with us your lecture about role hormone in CKD children. Maybe we will wait for a little more minutes so many doctors can join the webinar, and after that you can start your lecture then.
Sure.
So now is morning in Vietnamese, and a lot of doctors have to work hard and they have to finish their work, and then they can join to the webinar, so it's a little bit late.
Oh, that's okay. It's just, you know, it's 10 o'clock here. So.
Yes, yeah, I know. Yes, I know. Dr. Abi, because we don't have a translator, so you try to speak slowly so more Vietnamese doctor can hear and understand the content of your lecture.
Of course. Of course.
Is it difficult for her?
Don't make fun of me, Dan.
Anh Quang.
Hả?
Thứ năm tuần thứ ba thứ Thứ tư tuần sau có một buổi, thứ năm tuần sau có một bài nha.
Năm tuần sau hả? Điền update cái lịch lại cho anh đi, hình như là theo cái lịch là 2 tuần nữa mới có một bài phải không?
No, tại vì Denver bận á, chuyển tới thứ năm tuần sau.
Là cái bài mà rối loạn điện giải hả Điền?
Yeah.
Vậy là thứ năm tuần sau ha.
Yes.
Ít người tham gia quá ta.
Chủ đề này hay mà không ai nghe.
Cái lịch giờ tới giờ lui, thành ra là cũng có đăng thông tin cập nhật lên rồi đó Điền.
Cái bài này là đúng lịch á, không có dời.
Vô đi.
Dời một ngày, sorry.
Đang bật cái record rồi phải không Phương?
Bác sĩ trong khoa anh Quang xuống đủ vậy mà.
Chưa Điền ơi, bữa nay đang hội chẩn bệnh viện tới 2 ca lần, thành ra là bữa nay sáng nay hơi lu su bu xíu. Chắc khoảng 5 phút nữa đi Điền hả?
Ok, anh nói cổ đi.
Dr. maybe we'll wait 5 minutes more.
Okay.
Sorry, Abby.
Yeah, you owe me a lot of things.
Yeah, I owe you a lot.
No.
I will come back New York to treat you a
He
dinner.
doesn't come back. I always tell him come back to New York.
Now up to October.
Có bác sĩ dinh dưỡng lên nghe. Em. Rồi cảm ơn em. Tin của sang người diện cấp mới rồi đi.
Và nó gọi điện nó đòi cái này.
Recording in progress.
Dr. Abi and Dr. Ding, now I will ask your permission to give me some minutes to present your lecture and your CV. And after that, you can start your lecture.
Okay.
Kính thưa các quý đồng nghiệp, thì hôm nay thì trong cái buổi học tiếp tục của cái chương trình về quản lý bệnh thận mạng ở trẻ em, thì cái chủ đề của buổi nói chuyện hôm nay sẽ là cái điều trị cái dinh dưỡng và cái role hormone trong cái bệnh thận mạng ở trẻ em. Thì báo cáo viên của chúng ta bữa nay là bác sĩ Abi Baseli, phó giáo sư đến từ cái trung tâm nhi khoa trẻ em ở Cohen. Dr. Abi, you can start your lecture now.
Okay, thank you. Thank you for having me. I really appreciate the opportunity to present. So we're going to be reviewing today just the epidemiology of growth impairment and chronic kidney disease, the causes of growth impairment in CKD, outcomes of growth impairment in CKD, both if we treat it with growth hormone and if we don't treat it with growth hormone. And we'll end off talking a little bit about the nutritional considerations in patients with chronic kidney disease and how we can help to think about their caloric intake and their diets. So we start with a case presentation. We have a 13-year-old male. He has obstructive uropathy and chronic kidney disease stage 3. His height is very short. He's 143 centimeters with a Z-score of negative 2.3, and his weight is 45.5 kilo. It's the 32nd percentile on the WHO. He was started on growth hormone 3 years ago, and during this time, his CKD has progressed. His current estimated glomerular filtration rate is 35. So really what we want to understand is what are the factors that lead to growth impairment in chronic kidney disease, and what is the role of growth hormone therapy in CKD progression? So growth impairment is common in chronic kidney disease. It occurs in almost all children with any chronic kidney disease, and in children with end-stage kidney disease, over half of them will fall below the 3rd percentile for age, sex, and for their height. So these kids are short, okay? Impairment is observed at all levels of CKD. The lower your GFR, the shorter you will be. The greatest risk for growth impairment occurs if chronic kidney disease begins early in childhood, which are the children that we're all taking care of. But in recent years, with the access to growth hormone, pubertal height gain in children with chronic kidney disease and end-stage kidney disease has really improved in the last few years. So what are the causes of growth impairment in children with chronic kidney disease? Well, it's really multifactorial, and I'm not going to go through this entire image, but if you think about it, a lot of these babies are born, especially if they have congenital anomalies of the kidney and urinary tract, they're born preterm, they're very small. They also then are at risk of having malnutrition. They have the risk of metabolic acidosis, anemia, and we're going to go through a little bit about this, but they also have mineral bone disease, and that does not promote growth for patients. So going forward, you know, if we really think about the barriers to achieving a pro-growth state in children with chronic kidney disease, there are modifiable risk factors. So nutrition is a modifiable risk factor. We can make sure that our patients are taking in sufficient calories, but there are some non-modifiable factors like inflammation that contribute to poor growth. And each of these barriers must be addressed by the family and the interdisciplinary medical team to optimize conditions for a pro-growth state. So like we explained, if we're thinking about nutritional deficiency, patients with chronic kidney disease and children really have reductions in protein and nutrient intake, and they can be vomiting, they can have feeding problems, they can have reduced motility of the gastrointestinal system. And in reality, there's also abnormal secretion and destruction of gut peptides that cause this issue with dysregulated hunger and satiety. A lot of these kids don't want to eat very much. And when they do want to eat, they have a lot of oral aversions. They don't like certain foods and they want to just drink certain things, and it's very hard to feed them. Another major issue in poor growth is metabolic acidosis. This usually happens after development of chronic kidney disease stage 3. So once your GFR drops below 60. This acidosis can induce degradation of protein. It increases your own corticosteroid production, and it leads to end organ resistance to growth hormone, which we're going to get into a little bit later. And there was a paper published a little while ago in 2017 that basically evaluated patients with the lowest serum bicarbonate level less than 18. And those patients had the highest risk of chronic kidney disease progression and worsening secondary hyperparathyroidism, which lends itself to poor growth. So we just spoke about how acidosis really impairs bone metabolism and is related to secondary hyperparathyroidism. And this is just a summary of how that may happen. But if we want to break it down, essentially kids cannot grow taller. It's difficult to generate vitamin D. You stimulate PTH secretion in the setting of acidosis, and you really are essentially breaking down your bones in the setting of an acidic environment. So essentially, when you have a blood pH that's low, you really have these like ion exchanges inside of your bone, leading to poor growth. And you're also going to have direct cell-mediated effects of breakdown of your bone. So not just on the cellular level and not just buffering your bone, the acid inside of your bone, but on a cellular level, you are stimulating breakdown of bone as well. So this is not going to allow for statural growth or growth in height. Sorry. Okay. So hand in hand with what we just described in the setting of acidosis, whenever there's secondary hyperparathyroidism and mineral bone disease, this is a result that we all know as nephrologists of reduced phosphate excretion. You have impaired gastrointestinal and kidney reabsorption of calcium. And in the end, you have hyperphosphatemia and hypocalcemia leading to secondary hyperparathyroidism. And in reality, FGF23, which is high early on in chronic kidney disease, is increased in the circulation. And that is what is also starting to allow for dysregulated bone metabolism at this point. This next slide just basically describes everything that I just explained, where everything is disrupted in CKD. And all of these pathways need to be working harmoniously together in order for a child to grow. And when these things are dysregulated, you're already at a disadvantage to have poor growth and especially poor bone deposition of true bone as these children are growing. So a large part of this is also what we kind of hinted to is growth hormone or insulin growth factor 1 axis and resistance. So if you measured growth hormone levels in pediatric chronic kidney disease patients, you would see that there are normal levels of growth hormone or even high levels of growth hormone. But that is because there's reduced sensitivity of bones to growth hormone. If you measured insulin growth factor 1, IGF-1 levels, those levels are going to be low. And this is due to increased presence of elevated circulating levels of IGF binding proteins. So what is this resistance in CKD? You also have a reduced density of growth hormone receptors in target organs like the liver. And your serum growth hormone binding proteins, the cleaved product of the growth hormone receptor, is low in CKD and correlates with the degree of CKD and response to exogenous growth hormone. And we'll get through the IGF binding proteins as well. So we keep talking about all these things and we keep saying this, so I'm going to get to the picture. So essentially, you have an increase of these IGF binding proteins on the left of the screen that do not allow for free IGF-1 to allow for IGF-1 to be released and allow for the downstream effects of growth hormone to stimulate growth within the body. And this reduces the IGF-1 bioavailability. And therefore, you really are going to see that in patients who have increased levels of IGF binding protein 1 and binding protein 2, you are really going to have to give them a tremendous amount of growth hormone in order for them to stimulate any sort of a response. So just to circle back, and I don't want to spend too much time on this, there are certain hormones that are binding too much to the IGF-1. And if you have proteolysis of IGF binding protein 3, you have a reduction in IGF-1 circulating in the complex that IGF-1 usually circulates in, which is the IGF-1 bound to the IGF binding protein 3 complex. So you either have the other binding proteins holding on too much to the IGF-1, or you have not enough of the complex that brings active IGF-1 to its target receptors. And that protein, the IGF binding protein 3, is being broken down too much. This is just another illustration. And this is basically saying that substantial abnormalities are absorbed in the growth hormone, are observed in the growth hormone IGF-1 axis in patients with chronic kidney disease. So another possible pathway is the JAK-STAT signaling pathway, which is a defect in the post-receptor growth hormone activated Janus kinase signal transducer. And this pathway must be intact for growth hormone stimulated IGF-1 gene expression. And it's not intact in patients who have chronic kidney disease. In addition to the growth hormone axis, there's disturbances in the gonadotropic hormone axis in chronic kidney disease. So gonadotropic levels are high due to decreased renal clearance. Pituitary secretion of bioactive luteinizing hormone is reduced. So essentially, you have high gonadotropins, and you're going to have plasma testosterone concentrations that are decreased due to the decrease in LH, or luteinizing hormone, and the binding proteins are elevated, similar to growth hormone and the IGF-1 axis, and therefore there's less free hormone to stimulate puberty in these patients. So there are other growth hormone independent variables that can contribute to growth failure. So age at onset of CKD, the younger the age, the more likely you are to be short and have poor growth. If you think about the patient's primary disease, especially in those babies that are polyuric and are salt wasting, those children are at increased risk of growth failure. Patients are going to have calorie deficiency and abnormal protein metabolism, metabolic acidosis, which we spoke about, renal osteodystrophy, which we also spoke about, and prior use of glucocorticoids will also affect their bone health and their ability to grow and maintain a normal height for age. And this is just data from NAPROTAX, which is a consortium of the annual report of patients who were dialyzed within the North America, where the main point of this is showing you that a younger age at initiation of dialysis is associated with more severe growth inhibition. So our younger patients that have kidney failure that are going on dialysis are at the greatest risk of becoming short. So what do we know about these children if we let them grow poorly and have growth impairment? So the association of growth failure and survival in children with chronic kidney disease is demonstrated here. It's an old paper from the CKID cohort, the chronic kidney disease in children cohort. And what they're showing here is that if your age is young and you have growth failure and you have growth failure, all these children had growth failure, but these children all had height z-scores that were below 2.5. So essentially, compared to children in the green and red who were growing somewhat better, those who were younger were doing worse in terms of their outcomes of growth. And we see that again, that if you have severe growth failure, your risk of survival really was impaired. And if you have normal growth, your risk of survival is improved in patients with end-stage kidney disease. Not only should we be talking about death or life, but when you think about quality of life of our patients as they're surviving to older ages, we need to think about psychological development and quality of life. And children with growth hormone deficiency have poor psychological development, both because growth impaired children are perceived to be younger than their true age. If they're thought to be too young, it has been reported to be associated with poor life quality. And comorbidities, including ADHD, learning disability, mood disorder, and social isolation are oftentimes associated with children who have chronic kidney disease. So really, CKD progression contributes overall to poorer health and quality of life. So when we think about the composite neurocognitive function and quality of life of a patient, if we can prevent growth failure or we can prevent growth insufficiency, we can in turn help to improve some of our patients' quality of life and their overall health. And another study, just to try to convince us that this is very important, is that essentially what is being shown here is a study where they looked at your GFR and how fast patients declined. And those patients in short stature in advanced pediatric CKD is associated with faster time to reduce kidney function after transplant. So even if these kids get transplanted, if they already had very severe short stature prior to the transplant, post-transplant, their likelihood of a surviving graft is less. So it's not all sadness and doom and gloom. Growth hormone treatment on height standard deviations in children with chronic kidney disease has significantly improved their outcomes. And this slide summarizes data from 4 controlled placebo or no treatment clinical trials evaluating the effects of growth hormone on height standard deviations in children with chronic kidney disease and post-transplantation. And after 1 year, growth hormone treatment produced significant increases, which I know it's hard to see, but they're all in yellow, but they all moved over to the right, away from the dotted line over here, where you had a significant increase in height standard deviations as determined by the weighted mean difference, okay? So that's really important for us to think about. So what do we do when we have to prescribe growth hormone for our patients? So the European Pediatric Nephrology Association had come out with clinical practice recommendations for growth hormone treatment in children with chronic kidney disease. And I wanted to review them now because we now understand why and why it's important for us to treat growth failure. Now we need to understand how do we do that. So what does the European Society for Pediatric Nephrology group think about what we recommend and think about before starting growth hormone? So we need to remember that growth potential is assessed by a calculation of genetic target height on the basis of parental height. If two people have very short parents, they are not necessarily, I mean, if a patient with chronic kidney disease has extraordinarily short parents, if we look at where they are targeted to have their height based on their parental height, we shouldn't be overshooting it, but we should be taking it into account. And we also need to remember that our patients should have open epiphyses. They should still be undergoing growth. So you want to make sure that with a left wrist radiography, the epiphyses are open on X-ray. So how do we calculate a mid-parental height? It's the father's height in centimeters plus the mother's height in centimeters plus 7 centimeters for a boy or minus 7 centimeters for a girl. And you divide that by 2, and that's the child's height at 18 years. So we can definitely do that and see where the child is. And if the child is nowhere near that and they're not getting toward that, they may be a candidate. So what do we think about? We think about the age of the patient, their primary renal disorder, if they have any other systemic disorders, their stage of CKD, whether or not they have adequate dialysis, if they are on dialysis, what if they have a kidney transplant, what is their graft function? And most importantly, are they continuing on high dose glucocorticoid therapy? Because we know that glucocorticoid therapy can affect our bone mineral density and may negatively affect patients' ability to withstand statural growth as their bone is growing if they don't have the ability to mineralize their bones in a meaningful way. So what we also need to think about is we can't just start growth hormone if our patients have protein calorie malnutrition. We can't just start growth hormone if our patients have untreated metabolic acidosis or if they have hyponatremia, because we know that both acidosis and low sodium states have poor growth. So if we allow our patients to stay in a poor growth state, even if we're giving them the growth hormone that they have some insensitivity to, they really may not grow. So these issues need to be taken care of before we're considering growth hormone. We want to make sure our patients are well hydrated and that their secondary hyperparathyroidism, similar to what we just described with the glucocorticoids, is not totally and completely out of control. If you have PTHs in the 1000s, very, very high PTH, you're going to force a child to grow, and then they're going to break their bones because they have such demineralized bones or they have renal osteodystrophy. So when we think about weighing pros and cons with our patient, really when we say that almost all of our patients with stage 3 to 5 chronic kidney disease or end-stage kidney disease, 6 months and greater, should be candidates for growth hormone therapy if they have persistent growth failure, which is defined as a height less than the 3rd percentile for age and sex, and a height velocity below the 25th percentile for age. And the secondary issue is that you have to provide that no secondary causes are there, which really, and there is growth potential. So you need to make sure the epiphyses are open and that, you aren't completely and totally malnourished calorically when you're starting the growth hormone. Another recommendation from the group is that height between the 3rd and 10th percentile, but persistently low height velocity would be an indication for a patient to start on growth hormone. And in children who receive a kidney transplant and have persistent growth failure, as described above, we recommend initiating growth hormone therapy 1 year after transplantation if they do not have growth, and they are not on a very high dose of steroid when they're getting transplanted at that point in time. In those patients who have cystinosis, I don't know if there are many patients with cystinosis in Vietnam, but there are many patients with cystinosis in New York, but who have growth failure. Any stage of CKD at that point is an indication for initiation of growth hormone. So what are the most common side effects? Because this is what most of our patients are going to ask us. So intracranial hypertension is an important one. Eye exams looking for papillary edema could be important. Glucose intolerance, so monitoring of serum glucose and A1C is important. Secondary hyperparathyroidism or orthopedic complications, like we described, even if the mineral bone disease is well controlled, there still is a strong possibility that our patients are going to have accentuation of their parathyroid hormone going up, and they may be at risk of fractures if we aren't keeping a very close eye on their bone mineral health. There is some debate, but discussion about whether or not it can lead, as the body is growing very quickly, especially in children who have kidneys that are not sufficiently supporting the rest of the body. Can it lead to a accelerated decline in kidney function? And it can lead to pubertal acceleration. So in patients who we want them to grow, we don't want them to reach puberty too early so that we keep the epiphyses open. So it's important for us to look and Tanner stage our patients and make sure we aren't seeing signs of early puberty, to make sure that the growth hormone will be effective so that the epiphyses are still open, making sure that we're still growing and that we aren't accelerating puberty in younger children. So I do want to point out that a lot of my patients are very nervous about starting growth hormone when they have chronic kidney disease stage 4, because they say, even if it will make my child taller, won't starting the growth hormone worsen the patient's kidney function? And there have been a couple of studies that have looked at this, and really in prospective studies, it really hasn't been found to accentuate or accelerate kidney function decline. And I think it's important for us to explain to our patients that oftentimes, regardless of whether or not we treat with the growth hormone, the kidney function may decline, and the risk-benefit ratio of not growing and the quality of life and all the other findings that we just discussed are likely not going to outweigh the risk of having accelerated decline of kidney function. So are there contraindications to starting growth hormone? Yes. If someone has severe secondary hyperparathyroidism, PTH levels greater than 500, or an increased 9-fold about whatever is the normal range. If you've had an episode of a slipped capital femoral epiphysis, or any major types of fractures at the time, that is a contraindication. If the fracture has healed, that is no longer a contraindication. Severe diabetic retinopathy, having an active malignancy, or having had a malignancy within 2 years would be a contraindication. And after an acute critical illness such as heart surgery, abdominal surgery, trauma, or acute respiratory failure, we typically would hold off on growth hormone. So how do we give the medication and how do we monitor it? So usually the starting dose is 0.045 to 0.05 milligram per kilogram of body weight per day. And we give it by subcutaneous injections, typically in the evenings, to mimic the growth hormone peak in the nighttime that is available in patients who have their own endogenous growth hormone. And really the biggest part of growth hormone and what's difficult for it, at least for our patients, is that you keep having to get an injection or a shot. So we've been encouraging children around age 8 to 10 years of age to do the growth hormone injections on their own if it's possible. And this was like a pretty weak recommendation from the ESPN, but from a pediatrician and mother perspective, I think it's very important because the children are already potentially also getting erythropoietin or other types of injections, and giving them some independence and ownership over taking care of their own bodies is important. So what do we monitor? So clinic visits every 3 to 6 months. Realistically, in our practice, we see these patients almost every 6 weeks, maybe every 2 months. We're monitoring stature, your height velocity, pubertal development, skeletal maturation on wrist radiography, especially if you're seeing that those patients are developing significantly from a puberty perspective. We're monitoring kidney function. We also want to have a close eye on the serum glucose and the thyroid hormone levels. We want to measure serum calcium, phosphorus, and parathyroid hormone levels to best understand what their bone mineral densities are and what their secondary hyperparathyroidism is doing. And if we need to hold growth hormone, we can. And we also want to know what their serum bicarbonate is and correct it with sodium bicarbonate or whatever is appropriate to make sure that these patients are not acidemic and are not buffering their acid in their bone or causing poor growth. When are we reassessing growth hormone? If the height velocity in the first year of growth hormone is less than 2 centimeters per year over baseline, we really need to ask 2 questions. Are you giving your child the growth hormone? And then we can do things like measuring serum insulin-like growth factor 1 levels. We could think, is this patient growing and gaining weight? And do we need to weight adjust the growth hormone dosage? And we also want to take into account nutritional and metabolic factors as recommended before initiation of growth hormone. Maybe the child stopped eating, maybe they're no longer taking in calories. When do we stop growth hormone? If you show that there's no longer any growth potential by closing the epiphysis. If a patient has a renal transplant, we stop growth hormone for the year and we watch and see if that patient achieves catch-up growth. In a patient with very poor parathyroid hormone levels, very high levels, if a patient develops intracranial hypertension, we already spoke about the slip capital femoral epiphysis. If there is an unexplained decrease in estimated glomerular filtration rate, there is a recommendation to back off of the growth hormone. If the patient reaches his or her genetic target height percentile, you may say, okay, this is really the percentile that you're going to be on in your trajectory to get to your mid-parental height. Let's stop the growth hormone. And if they fall off that curve, you can restart the growth hormone. Or if you've reached your genetic target height and the patient has not yet reached puberty, you may consider stopping the growth hormone at that point. So we spoke a lot about making sure that our patients are optimized to starting growth hormone. And I wanted to bring that up first because I think that nutrition is very important in patients with chronic kidney disease. And as a physician, I honestly rely a lot on my dietitians and my nutritionists to help me best understand how to maintain our patients. It's currently like 10:40 p.m. in New York, and my nutritionist did not want to come on to this lecture with me, so I'm going to give it with her help because she helped me to prepare these slides. So really, our goals as nephrologists are to maintain an optimal nutrition status for our patients. We want to avoid uremic toxicity, metabolic abnormalities, and malnutrition. And we want to reduce the risk of chronic morbidities and mortalities, which can stem from being under and overweight. And we want to delay the progression of kidney disease. So what does a dietary assessment usually entail? We usually ask for a 3-day food journal or a 24-hour dietary recall to gather information on the quality of our patient's diet. And a 3-day record really gives you a better picture of regular eating patterns, especially if you include a weekend in addition to weekdays. But the reality is that most of our patients can't remember what happened the day before. So, a 24-hour can be adequate. And essentially, it's important to ask as many details as possible, such as how is the food procured and how is it prepared? What is your frequency of eating out in restaurants? What spices or condiments are you using? How much dairy are you eating? And what type of milk is purchased? These are all very important questions. And the growth parameters that we want to look at when we're looking at our patients give us more of an objective assessment of what their overall nutritional status is. So we want to look at their height, their weight and weight percentile, their BMI, body mass index for age percentile, and their weight gain velocity. And it's important to also do a quick physical assessment, looking at any signs of muscle wasting. You can measure the skin fold thickness, and mid-arm circumference has really been a useful tool and a quick tool to assess body composition. Looking at a serum albumin is also helpful, but it has become more controversial over the past few years. And the use of albumin to assess one's nutrition status is really, if there are no other inflammatory issues, I think it should be fine. But in reality, what we can also use is an NPCR, which essentially is a normalized protein catabolic rate, and it can be used to assess adequate protein intake in adolescents and adolescents on hemodialysis. You really want to get a better understanding, and there's a calculation underneath, and I'll share it with you if you don't have it, of what protein intake is like. If you have an NPCR less than 1 gram per kilogram per day, this can be associated with malnutrition, whereas if the NPCR is greater than 1 to 1.2 kilogram per day, that is associated with progressive increases in both parameters and allows for you to gain weight. So it's reported in grams of urea nitrogen per kilogram per day, and that's what we want to be calculating using one of the methods below. So what's important is if we're using our growth chat and our percentiles to monitor our growth, hold on one second. So we want to understand which charts we're using. In the US, we're oftentimes using the Center for Disease Control, the CDC growth charts, where we're looking at BMI for age, we're looking at stature for age, and we're looking at how that's going to affect itself. And when we look at the cutoff values for the WHO growth charts, we're talking about length for age, weight for length, percentiles, where we're saying that length for age less than the 2nd percentile is associated with short stature, and weight for length less than the 2nd percentile is associated with low weight for length, that child is malnourished, versus weight for length that's greater than the 98th percentile. So understanding how we best define poor growth is important. So these are just examples of the charts that we can be looking at. On the left is a very overweight boy. On the right is a young girl who both height and weight have really dropped off the curve, and they are very poorly malnourished. So early and aggressive correction of nutritional imbalances can improve the patient's growth, especially during the first 2 years of life, where the expected rate of weight gain is so high. This is when we try to achieve the most catch-up growth as doctors, especially for our preemie babies, so the babies who are born premature. So using the amount of grams the child gained per day since the last visit can help in deciding whether they have gained enough weight or whether changes should be made to their feeding regimen. So catch-up growth may be achieved by increase. So I think it's important to look at what is being presented here. Essentially, in premature babies, the less than two kilo, the goal is to gain 15 to 20 grams per kilo per day. And in those greater than 2 kilos, 20 to 30 grams per day. And accordingly for the other ages below. And it can help us to better understand what the weight was at the previous visit and the weight at the current visit, subtract them and divide them by the number of day and see if our weight velocity is appropriate. How are we going to allow for catch-up growth if we are not meeting our weight velocities? We're going to discuss, but what we want to think about is perhaps increasing caloric concentration of the baby's formula, adding a modular, like what we have in the US is DuoCal and or oils to a child's feeds, which are low in sodium, potassium, phosphorus, and other nutrients. And a lot of times, this is also when we would consider increasing both the caloric content, but also considering growth hormone at the same time. Many of our babies will need a growth, a G tube or a gastric tube to help to feed and tolerate the feeds and the amounts that they need, a lot of times due to feeding aversion. So what are the appropriate calorie and protein recommendations for the premature infant? So this chart shows the calorie and protein recommendations for premature infants. Unfortunately, there are no published references for protein intake for a premature infant that is on dialysis. However, if you take into account that protein needs for term infants are increased, especially in peritoneal dialysis, by 0.1 to 0.35 grams per kilogram per day, then we can really say that in hemodialysis preemies, they probably need somewhere between 3.5 to 4.5 grams per kilogram per day. And in patients who are on PD and are premature, they need 3.75 to 4.7 grams per kilo per day of protein. It's important to use this as a starting point and monitor your growth parameters closely and make modifications to calorie or protein intake based on assessment of current intake, protein intake and growth. And the BUN creatinine ratio can also be used to assess for too much or too little protein intake. And a normal ratio is around 10 to 20. If the ratio is high, perhaps not enough calories, too much protein or breakdown of lean body mass, or the patient needs more dialysis. If the ratio is low, however, this can be a sign that the patient is not getting enough protein or has potential fluid overload. So when we think, this chart represents the protein requirements for infants and children who are not premature on dialysis. For chronic kidney disease, it is the same as the recommended amounts for healthy children. There's no evidence that protein restriction has nephroprotective effects, that the kidneys are protected by restricting protein. However, excess protein should be avoided. For hemodialysis and peritoneal dialysis patients, the recommendations are only slightly higher. Unless you have a very picky eater or a patient who has suboptimal intake, protein supplementation is rarely required. So this chart shows you how to estimate calorie intake for children with both CKD and dialysis. Remember that adequate intake of energy is important, not only to promote weight gain and growth, but also to prevent protein from being used as an energy source through gluconeogenesis. These recommendations are based on healthy children, as there is a lack of evidence to suggest that kids with CKD and dialysis, as I said before, have greater energy requirements than healthy children. So here's how you would measure your estimated energy requirement for a patient and calculate their total caloric intake that you would be prescribing or recommending. So what this becomes the most complex with are infants. So in infants, we really need to understand, once we've said this is what is our calculated caloric goal, let's talk about how we can meet those requirements in our infants. Many times it's difficult to get our infants to drink a higher volume of formula to increase their caloric intake and achieve their estimated needs. So they may be vomiting or have increased fullness if they're on peritoneal dialysis. So concentrating the feeds becomes a very important technique in order to increase caloric intake. It's really important to ask parents how they are mixing the formula, how many ounces of water to scoop of powder, and how many ounces their baby is taking in per day in order to calculate how many calories they are receiving. So this is a little bit of like a cheat sheet chart for formulas that have 19 to 20 kilocal per ounce. So that's all the formulas that are listed on the right. I'm not sure what formulas you have available in Vietnam, but the most common formula that we use for our chronic kidney disease patients is Similac PM6040, which is a low potassium, low calcium, low phosphorus, low sodium formula. Essentially, I'll give you a comparison of what we have, the different formulas and supplements that we typically use. So breast milk is really considered the gold standard, even for our chronic kidney disease babies, because as you can see, it really has more or less the lowest renal solute load. NeoSure is a formula that is not really a renal formula, but a lot of times our preemie babies are on this formula once they are discharged home due to its increased nutrient density, especially in calcium and phosphorus. Similac is the standard non-renal formula within our hospital, and Similac PM6040, the one I was recommending before, is the renal formula. Oftentimes it may be used even after age 1 to delay switching from cow's milk if potassium and phos are still of concern. And we'll talk about that in a little bit. So over here we have Suplina, Renastart, Renalcal, Renastep, and these are all supplements for older children. And another thing that we do with our formulas is that we will sometimes utilize Kayexalate or sodium polystyrene to mix with our formula, shake up the formula, let it sit, and decant the formula without the potassium in order to feed it to our children. So on the next slide, we're really talking more about supplements for our children who are no longer infants and are no longer toddlers that are available. We have a couple of renal supplements. Nepro and Suplina are supplements that can be taken in on their own. So if you have a G-tube fed baby, a gastric tube fed baby, you can give Suplina or Nepro. Renastep is an interesting option in the setting that it's a supplement that it's very low in renal solute, but it cannot be given on its own because it is extraordinarily hypotonic. It's just used as an addition to the diet. If we aren't able to use these commercial renal supplements, addition of fats to the diet, such as butter, olive oil, whipped cream, middle chain triglycerides or MCT oil, non-protein calorie supplements like DuoCal, which are essentially like powdered fat that can be added to the meals, are also important. And of course, enteral tube feeding should be considered when a child is unable to meet nutritional goals orally. Because continuous feedings are usually given at a very low rate and often need to be around the clock, they are usually tolerated the best and are often initiated in our hospital or even as an outpatient if the patients are not tolerating. And over time, these feeds can be condensed so that there is less pressure of always having the patient hooked up. You can discuss whether you want a nasogastric tube or a gastric tube. Majority of our patients have gastric tubes just based on especially the young age of the patients who need it. It's important to think about when to send our patients to a feeding therapist and getting other discipline involved early. If you see babies who are refusing the bottle, who are only eating certain foods, who have difficulty controlling their mouths, or have poor weight gain due to picky eating, they may need to already be involved with a speech and swallow specialist. So this is just ways of, monitoring tube feedings in infants and young children with chronic kidney disease, and how to think about initiating the feeds, what your daily increase is going to be, and what your goal feeds are going to be, and what you would set them at. So children with chronic kidney disease or end-stage kidney disease are expected to meet 100% of the daily recommended intake for vitamins and minerals. And children who eat healthy amount in a variety of food or receive a majority of their nutrition from complete enteral feeding may meet 100% of the daily recommended intake and may not require supplementation. But the risk for deficiency is increased by limited volume or variety of dietary intake, whether or not they have any gastrointestinal absorption issues, or if they have losses in dialysis. Children on dialysis should be placed on a water-soluble vitamin in order to compensate for those losses. So especially vitamin C, thiamine, niacin, riboflavin, folic acid, B6, and biotin, and pantothenic acid. And there are a couple of vitamins that are on the market, Nephrovite and Nephronex, which we have been using in our children. Nephronex is a liquid and Nephrovite is a tablet. And another vitamin worth mentioning is vitamin K, as it is essential for maintaining bone health and your clotting factors within the blood. But there's little research on supplementing it in CKD, and vitamin D status should be monitored regularly. So whenever we have patients who are admitted, we say we need to put them on a renal diet. So what does that mean? A low sodium diet is recommended even in the earliest stages of chronic kidney disease. When we talk to our patients, they'll always tell us, no, doctor, I don't give more salt to my food. But 80% of salt from our diet is already in our food. So what we tell our patients is cook your meals from scratch, read your food labels, add another flavor to your food, use other condiments like Mrs. Dash, and eat fresh foods. Don't eat frozen dinners or meals, processed meats or cheese. Canned foods have a lot of sodium. Condiments like soy sauce, teriyaki sauce that are already pre-made, and going to takeout in restaurants are really just going to have a lot of sodium. There are cheeses that have low sodium, like low sodium cottage cheese, fresh mozzarella, ricotta, Swiss cheese, whipped cream cheese. And essentially, when you are cooking your meals from scratch, think about breads, because breads that you do not make from scratch at home often have increased phosphorus and salt. So I just wanted to bring this up. Like if you look at a Burger King's menu, the small unsalted fries has, like, just to understand, has 300 milligrams per serving. But otherwise, all of these other options have 1,300 to 2,000 milligrams of sodium in them, which is above that of the daily recommended intake for an entire day. And if you look and you think you're going to be healthy by sticking to a salad, you are wrong. A healthy garden salad with grilled chicken is still over 800 milligrams of sodium. And that is without dressing. Once you add dressing, you're at 1,200 milligrams. And the small unsalted French fries, if you look, I don't know if they're here, but I know this from all my patients, it's like only 300 milligrams of sodium. So that's what we tell all our patients to eat, are the small unsalted French fries once in a while. So moving on to potassium, we start to restrict potassium in the diet only once we see elevated serum levels. Rather than giving patients a specific goal, what their potassium intake should be, we work on what their current intake is and cut out foods that are the easiest for them. For example, limiting milk and cereal may be difficult for most children, so we might work on other things like switching from orange juice to apple juice. It's important to keep the restrictions simple and not overwhelming in order to help children to maintain the adequate amount of caloric intake. The good thing is that potassium, at least in America, can be found on a food label. So parents and older children can easily learn to look for low potassium options. If you see greater than 250 milligrams in a serving, we usually will say that is very high. So we will go through a lot of these vegetables and fruits and recommend that patients are avoiding them. So really, when we think about vegetables, children who do not want to get rid of their favorite vegetable, most children love potatoes. They always want French fries. They can eat in a moderate portions if they are leached of its potassium, and leaching the potassium will cut potassium content in half. So essentially, we say that you should peel and place the vegetable in cold water, slice them, rinse them in warm water, then soak them for 2 hours. Use 10 times the amount of water to the amount of vegetable, and then rinse under warm water again, and then cook the vegetable with 5 times the amount of water to the amount of vegetable. And this is based on the National Kidney Foundation. And essentially, it's important that the broth of that, the fluid surrounding that you're using has a lot of potassium. So they should not be eating soups made of potato soup, because that water that you keep pouring out and leaching the potassium off of is very potassium rich. So what about phosphate? So the biggest issue in the US with phosphate is that it's in everything, but it does not need to be labeled in terms of its daily value on the ingredients. And reduction of phosphorus intake is considered once our PTH levels are above normal range, even if our phos levels are somewhat normal. So because phosphorus is used as a food additive to preserve foods, and it keeps food on the shelf longer, manufacturers are not required to list phosphorus content. So instead, we need to look in the ingredients for phosphorus, or you just don't buy anything processed. So that's why we say eat fresh foods. Plant-based proteins have lower bioavailability of those phosphorus. Thinking about whole grains, where there's a lot of inorganic phosphorus, organic versus inorganic. The inorganic phosphoruses in sodas, deli, bacon, dairy, and chocolate are much more easily absorbed than the ones in healthier plant-based foods. And thinking about alternative milks like almond, rice, soy, oat are very important. So really, when you think about cheese, that's something that patients really need to avoid. Ironically, the one cheese that is on this picture that has the least amount of phosphorus is the cream cheese. So a lot of our patients, if they do like cheese on their bread or on their toast, we'll let them have a small smear of cream cheese on their bagel. So if you look, right, like the butter and the cream cheese have more or less the lower phosphorus containing materials, whereas the other cheeses have very high content of phosphorus. Heavy cream and whipped cream have less. So there's an app called Chronometer, which it's very hard to know what is in the food that we are eating and what is there. So I don't know if it's available in Vietnam, but we use it here in New York. And it's actually been helpful in understanding what nutrients are in the foods that we are utilizing. And they do have a recommended phosphorus amount in certain foods. So it helps parents to pick foods when we're thinking this through. So what's the best diet for chronic kidney disease patients? After correcting any abnormalities in the potassium, phosphorus, and encouraging lower sodium or fluid intake, research has shown that eating more plant-based protein like tofu, lentils, nuts, soy are less toxic to the kidneys and can potentially delay progression of kidney disease. This is not very practical for children, especially very picky eaters and the ones who already have a difficult time managing all their restrictions. However, it is important to discuss with our chronic kidney disease patients, and I feel that it's easier than ever, at least in the US, to make healthier swaps, because patients, people who don't have chronic kidney disease all want to be vegan. They don't want to eat meat, they don't want to eat eggs, they don't want to eat cheese, and there are a lot of plant-based options that are making it easier to make meatless, meat. So we have like all these like pea and plant-based proteins through kale and chickpeas and all different kinds of beans and different things. So these are great options for our patients because the bioavailability of the phosphorus in these meals are less. There is a decent amount of sodium in the prepared meat patties, but there is less than in a regular burger that you would be ordering out from a restaurant. So to finally to end off our conversation, originally we had a patient that had poor growth. We wanted to start them on growth hormone. Hopefully we did, and they started growing. I wanted to end off with a case study of an 11-month-old ex-35-week preemie with chronic kidney disease on peritoneal dialysis. Corrected BMI for age is 7th percentile, and they're tolerating breast milk, but they have high potassium levels. What are our options based on what we just discussed together? So we could decant the breast milk with K-oxalate or sodium polystyrene. We could mix the breast milk with the sodium polystyrene, allow for the sodium polystyrene to get to the bottom of the bottle that we're utilizing. And then you could switch to Similac PM6040, but the amount of potassium in breast milk and PM6040, there's probably less potassium in K-oxalate. I'm misspeaking, in breast milk. So therefore, you may want to decant the PM6040 with K-oxalate as well. Diluting the breast milk would not be a good answer, and mix the expressed human milk with Renistart, which is a supplement that is low in potassium, might be the way to dilute that breast milk, because you're diluting it in the sense of potassium intake, not in caloric intake at that time. So those are a couple of the options, and a situation that we often will come up with is, what are we going to do with this hyperkalemic baby that's only on breast milk, and how are we going to think this through with the family? The other thing we would be doing, even though it's not an option here, is we would be discussing whether or not the baby is taking in a tremendous amount of avocado or a tremendous amount of potato that is not leached, or think about our high potassium foods. And that's really it. And here are my references. I appreciate everyone for listening. If there are any questions, I'd be happy to take them.
Thank you a lot for your practical and detailed lecture about management, nutrition, and GH treatment for children with CKD. Now it's time to question and answer. Các đồng nghiệp ở các điểm cầu, nếu mà có câu hỏi gì đó thì xin trực tiếp đặt câu hỏi, hoặc là có thể nói tiếng Việt, và ở bên này thì bác sĩ Duyên sẽ hỗ trợ thông dịch cho các quý đồng nghiệp. Duyên có câu hỏi gì không?
Cái way của CT đó để can thiệp của bệnh nhân thì thấy họ đưa ra một cái bảng là cái đó là tăng theo ngày, cái số gam tăng theo ngày, đúng không? Nhưng mà nếu vậy thì mình tính cho bệnh nhân là tính tăng theo tháng, mình chia cho vào tháng.
Không, thật sự không. Trước nó có cái chỉ định, trước nó có cái chỉ định là cái high velocity là bách phân vị tới bao nhiêu, rồi cái Dương vô sau, thành ra Dương không thấy cái bảng kia là chỉ để coi ngắn gọn, coi trong một cái thời gian ngắn thôi. Dương có hỏi gì về cái chế độ ăn cho bệnh nhân không? Có.
Trong cái đánh giá dinh dưỡng thì lúc đấy họ có một bảng đánh giá dinh dưỡng là có cân nặng chiều cao, rồi đánh giá nhật ký ăn 3 ngày đó. Thì lúc đó thì em không thấy là có xét nghiệm vitamin khoáng chất, tức là mình có routine đi xét nghiệm vitamin khoáng chất cho bệnh nhân suy thận bệnh không?
Dương hỏi đi. Dương nói tiếng Anh còn trùm hơn anh nữa. Hỏi đi. Nói trực tiếp với cái máy.
Em ngồi trên
Ngồi đi, ngồi đi.
Excuse me, I have one question. Can you hear me?
I hear you.
Thank you. I want to know about the nutrition assessment. So, do you have the test, vitamin test, or the mineral test routinely for the patient with chronic kidney disease?
So honestly, we will do B12 in our patients a lot of times, especially those who are on high flux dialyzers, if they're on dialysis, because the high flux dialyzers will get rid of the middle molecules quicker. And we are most worried about that because we're always dealing with anemia. And when we're thinking about the MCV, the cell volume, like, you know, in a normal kid, right? If the B12 is low, you say, oh, the MCV is going to be high, right? Because you have a macrocytic anemia. But in a patient who has erythropoietin dysfunction, right? Like they, you know, we already have that. We have anemia with iron, and you could potentially have low B12. It could be a mixed picture. So in our patients who are either on high flux dialyzers or who have very difficult time managing their anemia, we get B12 and folate levels. Our nutritionists want us to get all the other vitamins levels that we are giving them with the Nephrovite, and we don't routinely get them now. There are other centers that will twice a year see where patients are with those specific nutrients, especially the water-soluble vitamins on patients on hemodialysis, if those patients are on hemodialysis long enough.
Dịch đi cho mấy bạn nghe.
So hold on a moment, I will translate for everybody.
Thank you.
Câu hỏi là mình có nên làm xét nghiệm vitamin khoáng chất cho những bệnh nhân suy thận mạn hay không? Thì cô có trả lời rằng là cô ấy không thường quy làm, nhưng mà chú ý tới vitamin B12, tại vì trong cái giai đoạn mà mình thẩm phân phúc mạc hoặc là mình lọc máu mà cái tốc độ cao này, lọc máu thì là bệnh nhân có khả năng là bị mất vitamin B12, nên là chú trọng vô cái đó. Còn một số chuyên gia về dinh dưỡng ở bên đó thì họ cũng yêu cầu là làm tất cả các xét nghiệm về vitamin và khoáng chất, thì cô khuyến cáo là cô làm khoảng 2 lần một năm đó. Tại vì những bệnh nhân mà và chú ý là những bệnh nhân mà ví dụ như là khi mà mình thấy bệnh nhân thiếu vitamin B12 thường là hồng cầu sẽ to, nhưng mà những bệnh nhân này sẽ thiếu sắt kèm theo, nên là mình sẽ có thể không thấy cái hiện tượng đó, nên mình sẽ phải làm cái nhóm vitamin mà tan trong nước. Tại vì do là bệnh nhân bị thẩm phân phúc mạc và bệnh nhân lọc máu thì là cái vitamin tan trong nước rất là dễ bị mất. Đó, thì để ý là cô ấy giảng giải như thế. Dạ, em thấy có một câu hỏi nữa. Chuyên gia dinh dưỡng không? Bác sĩ chuyên khoa thận thiết kế. We have one question. It's a very interesting question. That's about the diet for the patient with chronic kidney disease. So the clinical doctor can recommend for the patient, or necessary to ask for the nutritionist to involve in the diet for the patient.
So I think it depends on how accessible your nutritionist is to you. I work in 2 different hospitals. I work in one hospital where I have a nutritionist, I have a social worker, I have the nurses, I have a million people. It's like a very nice setup. It is better for the nutritionist to talk to the patient for sure. I work in another hospital where it's just me and a nurse assistant. I am the nutritionist, you know? So it really, I think, where do I think the patients do better is in my major center, and that major center has dialysis and transplant. Whereas my smaller center, where it's just me and the nurse assistant, that's a patient with chronic kidney disease, where I'm trying to help them manage the best I can with the information that I have. to help them. I think once they reach dialysis and transplant, it's very beyond us as physicians with the time that we have to adequately go through it. That being said, if you have the opportunity for your chronic kidney disease patient to speak with a nutritionist, even once or twice, it's probably better than speaking with me 10 times.
Vâng, cô ấy trả lời là nếu mà tùy vào cái bệnh viện đấy, nếu bệnh viện đấy có một cái teamwork rất là nhiều cái nhóm chuyên gia khác nhau thì nếu mà bệnh nhân suy thận mạng được tiếp cận với lại bác sĩ lâm sàng và bác sĩ dinh dưỡng thì cũng rất là tốt. Còn nếu mà bệnh viện mà mình không có được cái bộ phận dinh dưỡng thì lúc đó thì mình sẽ phải tìm hiểu để hướng dẫn dinh dưỡng cho bệnh nhân. Nên là những bệnh viện mà có được cái thẩm phân phúc mạc hoặc có những cái kỹ thuật cao hơn thì chắc chắn là phải xây dựng một cái bộ máy teamwork gồm có nhiều chuyên gia để hỗ trợ cho bệnh nhân. Yeah.
So, Dr. Abi, the treatment fee for growth hormone in America were paid by the National Health Insurance, or the patient had to pay for themselves.
So insurance in America will pay for growth hormone
Yes.
for the indication of chronic kidney disease, stage 3 or greater. It's a huge deal because it didn't used to be that way. And they used to not, there were a lot of laws that had to be passed in order for all our children to be eligible to get growth hormone. But it's actually the easiest way to get growth hormone in America is to have kidney disease.
Yes. In Vietnam, growth hormone is very expensive. And we don't have experience on treatment growth hormone for patients with CKD, but for patients with short stature widow CKD, we have some experience to treat for those patients. Can you differentiate between the difference between growth hormone for short stature with widow CKD or with CKD?
So we give so CKD, so what you're saying is if a patient has a growth hormone stimulation test in Vietnam and they fail the growth hormone stimulation test, they would be eligible for growth hormone. Is that what you're saying?
Ở Việt Nam á, thì mình chỉ điều trị khi mà bệnh nhân fail cái test kích thích của RAF. Đấy cũng mong anh là vậy đúng không?
No. I just asked you in Vietnam for patients with short stature widow CKD, we had to perform GH stimulation test, but in children with CKD we do not perform this test.
Right.
But because most of our patients with CKD in Vietnam is not rich enough to afford for growth hormone, so we don't have experience to treat growth hormone for such patients. And we just use growth hormone for patients with the CKD.
Got it. So you use it for
And I want
patients
to
with-
know, can you emphasize the difference between GH treatment for short stature baby with CKD or widow CKD? Any difference between
I see.
Yes.
So we usually start, I'll be honest, I'm not as familiar with the growth hormone utilization without CKD. I'm very used to it in my CKD patients. I think that the dose that you would start for a patient who was just growth hormone deficient and not resistant, the dose is lower. So
Yes.
when I talk to my friends in endocrinology who prescribe growth hormone for children who need it for other reasons or because they just feel short and they want to be taller and they just have short stature, they will start it at a little bit of a lower dose than we will for growth hormone in CKD. And that is because of the resistance of the receptors and because of the low bioavailability, the fact that the IGF-1 is harder to get in patients with chronic kidney disease. So you have both receptors that are down for the growth hormone, and you have the next, communicator in the pathway, the IGF-1 being low, that you need a lot of growth hormone on board in order to stimulate a response in our patients. So if I'm comparing patients who are on growth hormone with CKD, we need higher doses to start and to go up with for the growth hormone to see a true increase in growth in those patients, whereas a patient who is just deficient would start at a lower dose.
Em xin dịch lại chứ. Đơn giản là anh Quang có hỏi là ở Việt Nam thì những bệnh nhân suy thận mạng thì đa phần thì đều nghèo. Mình ở bệnh viện Nhi đồng 1 thì chỉ có kinh nghiệm là điều trị hormone trên những bạn mà bị lùn do thiếu hormone tăng trưởng thôi, thì anh muốn hỏi là có sự khác biệt gì trong cái chuyện mà mình điều trị hormone tăng trưởng trong những bạn mà suy thận và những bạn không suy thận. Thì cô trả lời là cô thì không có kinh nghiệm nhiều trong điều trị những bạn mà bạn điều trị không có suy thận, nhưng mà cô có nói chuyện với những cái người bác sĩ nội tiết á, thì cái liều mà mình sử dụng là GH ở trên những bệnh nhân mà suy thận mạng á, sẽ cao hơn nhiều so với những bệnh nhân mà không có suy thận, là do thứ nhất đó là do cái tình trạng đề kháng GH, và thứ hai là do bị giảm cái ái lực và do cái tăng cái protein vận chuyển trong cái GF1 á, cho nên là cái liều mà mình dùng cho những bệnh nhân suy thận mạng sẽ cao hơn nhiều so với những bệnh nhân không suy thận mạng.
Can I ask a question?
Yes.
Câu hỏi thêm với câu
Do
hỏi.
you transplant babies? Like, how big does the baby have to be or the child have to be to get a kidney transplant?
We do not perform kidney transplant in our hospital.
Got it.
It's just in the near future, maybe next year or the next 2 years, we are
Oh, wow.
planning to perform that procedure in future. Now,
is there transplant in Vietnam?
yes, for pediatric
Yeah.
CKD, we had to center in Vietnam can perform pediatric renal transplant. In Ho Chi Minh City is Children's Hospital number 2, and in of Vietnam is National Children's Hospital in Hanoi. And
how big do they have to be to get, because we say 10 kilo to get a transplant, that's how big you have to be. And I'm just wondering, because it takes a very long time, even with growth hormone, for babies to get to be 10 kilo to be able to do a transplant. I'm amazed and happy that babies can go to those places and get transplant once they grow to be big enough. But is there a size that you usually use when you're referring them to those places?
Maybe in Hanoi, in National Children's Hospital in Hanoi, they already have children renal transplant, maybe 10 kilogram. The lowest weight for the patient maybe 10 kilogram. I don't know exactly, but I remember that.
Yeah.
So you can start raw hormone treatment for little baby below 10 kilogram.
Oh, we do it in 6 months and older.
Yes, thank you.
May I ask a question?
Sure.
Yes.
Hello, my name is from Children's Hospital 2. In Ho Chi Minh City, we have the kidney transplantation, and the small next baby were 18 kilogram. Yeah, we transplant from 18 kilogram in National Hospital in Hanoi. They transplant 12 kilogram. Yeah.
Oh, wow.
And we would like to ask you, can you share your experience about growth hormone treatment for patients after kidney transplantation? You know the indication. You show that they have pre-corticosteroid, but we rarely stop steroid after transplantation. We usually use the low dose of steroid. If the patient cannot catch up the growth, can we use the growth hormone?
That's a great question.
Yeah.
I think that these are recommendations that I was sharing from you from the European Pediatric Nephrology Association. They also make a recommendation that if the PTH is above 500, then you stop the growth hormone. We don't do that. We say 1,000. That's when we stop it. And a lot of times we'll use calcimimetics like cinacalcet or other types of calcimimetics to bring down the parathyroid hormone, hold the growth hormone when it hits 1,000, and then keep going with the growth hormone even if the PTH is above 500. And I think it's because the reality of medicine does not fit with the perfect recommendation of the European Pediatric Nephrology Association. So the same thing. I think if you have a child who has had a recent rejection of the kidney and they are on high dose steroids, then that would definitely be a situation where I would rethink utilizing growth hormone in that patient, because the risk benefit of achieving catch-up growth compared to the risk of having a fracture is going to be, not comparable. But if you're on very low dose steroid and you're on calcium and vitamin D at the same time, and you're monitoring the secondary hyperparathyroidism factors that are associated, right, with bone mineral health, I think that may be appropriate. You should just proceed with extreme caution.
Thank you for your answer. And the second question, I would like to ask about the monitoring the patient with growth hormone treatment in CKD. What is the target range of IGF-1?
I'm going to be honest. I look it up every time and I talk to my, so I'll tell you, usually my target is growth. As long as the patient is appropriately growing, and usually they grow, especially post-transplant, they grow, because the degree of resistance that patient has, oftentimes the patients that don't grow are the patients that have had some kind of complication or a little bit of rejection. So they have a stronger degree of chronic kidney disease, I think, contributing to why they are not growing at that time. But at the doses that we have, I've only in 1 or 2 patients had to send IGF-1 levels because they aren't responding. And in a lot of those patients, I send them, but I say, I know why this patient isn't growing. It's because they're not eating anything, or because they're really not taking the hormone or anything like that. I can email Dr. Duang, who helped set up this thing with my friends who are endocrinologists, and they may be able to tell me the number. But what I know as the nephrologist is, if it's not working, then that's when I start thinking, are you eating? Are you taking the medication at all? And should we be measuring IGF-1 level? Because that can sometimes tell you if you're taking it, because it should be higher than low, right? Than we were expecting. How high, I have to tell you when I look it in a book. I don't know.
Thank you so much. Because with the patient with growth hormone deficiency, the target range may be 0 to +2 SD, but the patient with other indication is maybe 3 SD, because safety of patient in the future.
Yeah. Interesting. I'm going to email Dr. Duang. I'm going to ask. I don't know. You seem to know.
And the third question I want to ask you to have get the experience of the growth hormone after kidney transplantation. How about the effect on the red function, such as rejection, something like that?
We haven't seen rejection.
Yeah.
Oftentimes, as the children grow, they become, you know, they have their own mind of their own, and then they decide not to take their medication, and then we see rejection. But we haven't seen the growth hormone related to either graft dysfunction or rejection of the kidney. That has not been found.
And now, what time? The time after transplantation, after 1 year or 2 or so?
1 year.
1 year. Yeah. Thank you.
If you haven't reached catch-up growth.
Yeah. Thank you.
Nghĩa là ghép thận thì vẫn phải xài, nhưng mà chờ 1 năm thì là cố ngưng. Nếu mà nó
Sorry, Nguyen. We can stop here a little bit late here.
Yes. Yes. Dr. Adi, maybe another question. Only another question. Although
Sure.
we know it's a little bit late in America.
Yeah, I'm sorry. I just have a quick question about the phosphate binder. If the patient have the phosphate high,
I think we talk about that. Yeah.
Yeah. So do you use a phosphate binder for the patient if concluding
Yes.
with the diet with
Yes, if
reduced
dietary control of the phosphate is not enough, then we'll either use calcium carbonate, calcium acetate, or sevelamer, which is a non-calcium containing binder with meals. You know, a lot of the adult data in chronic kidney disease is really discussing cardiovascular problems related to calcium phosphorus metabolism and the need to keep phosphorus normal, and probably the need to keep calcium low normal and not even mid to high normal, because of the risk of calcium and phosphorus getting together and precipitating out and causing vascular calcification and whatnot. So we try in most of our patients, unless they really have low calcium, to avoid calcium binders. We prefer the non-calcium binder like sevelamer, which will be approved by our insurance if you tell them that they tried the calcium, but their calcium levels are moderate to high, and we don't want to continue with the calcium binder. So usually if the phosphorus levels are uncontrolled and high, we will start a binder, and depending on what the serum calcium levels are, that's what helps us decide whether we use a calcium binder or whether we use a non-calcium binder.
Do you have experience on the dose of phosphate binder and calcium binder in pediatric patient?
So I don't know if they have Tums in Vietnam, but do you have Tums? Do you know what I'm talking? Deanne, you know what I'm talking about? So those are like easy for people to get, and they're very reasonable and cheap. So usually like in a little kid, we just start half of a Tums, and which is I think 200 milligrams of calcium phosphorus there. And then in a bigger kid, we'll start a full Tums with each meal, and it's easy for them to buy and to then go out and get. As they've had with sevelamer, we'll do 800 milligrams TID with meals, and we can go up to 1600 milligrams with meals, and then 800 with our snacks.
Thank you. Thank you so much.
Bác sĩ Thì Dương có hỏi là sử dụng cái phosphate binder trong những cái trường hợp mà tăng phosphate máu đó, thì cô nói là hạn chế cái phosphate ở trong chế độ ăn, mà nếu phosphate vẫn còn cao thì cô sẽ xài thêm cái phosphate binder. Thì có thể khuyến cáo xài những cái phosphate binder mà dựa trên calcium, như là calcium carbonate hoặc là calcium acetate đó. Còn nếu mà có thể dựa trên những cái gắn phosphate mà không có calcium như là selenium á, thì làm sao đó để giữ cho cái nồng độ phosphate ở mức độ bình thường, còn lại cái calcium thì ở mức độ hơi thấp, để tránh cái sự kết tủa của tinh thể calcium phosphate ở ngoài cái kết làm cái canxi hóa của mạch máu, hoặc là ở ngoài mạch đó. So thank you a lot for your previous time sharing with us about management, nutrition and growth hormone treatment for children with CKD. It's very interesting and practical. So thank you a lot again. It's late in America, so I good night, Dr. Abby and Dr. Ding.
Okay, thank you so much. I appreciate learning from you guys as well. Thank you.
Thank you so much, Abby.
Thôi chào quý đồng nghiệp, thì cái buổi nói chuyện hôm nay cũng là kết thúc rồi. Thì cái bài báo cáo của cô Anby đó có ghi âm lại và chúng tôi sẽ đưa lên trên cái group học để cho các bạn có thể lấy về nghe lại. Cái bài này rất là thiết thực và hấp dẫn cho cả các bác sĩ thận lẫn như là cái bác sĩ dinh dưỡng mà ở trong các cái bệnh viện có chăm sóc cho những cái trẻ suy thận mạng. Xin cảm ơn tất cả các quý đồng nghiệp đã chú ý lắng nghe. Chào Quỳnh nhé, Quỳnh ơi.
Dạ, chào anh Quang.
Rồi
Chào
thôi
anh Điền.
chào Vi, chào Vi.
Chào
Bye
anh.
bye ha. Rồi bye bye.
Bye.
Bye, chúc anh Điền ngủ ngon.